So, in the second session for day one at the Sexual Health Conference, I attended a session that was looking at a variety of different things, but the main thrust is really in testing for gonorrhea, testing for resistance, and Mycoplasma genitalia as well. So the first speaker was Rebecca Guy from the Kinsey Institute, who was looking at the Tango study, which was testing for chlamydia and gonorrhea in a point of care test. Now, one of the issues in the northern part of Australia is that there is a high prevalence of chlamydia and gonorrhea. However, it can take a very long time for people to get from testing to diagnosis, and in some cases up to 21 days, and that can be due to limitations with getting the samples to the lab, but also getting in contact with people as well. By using point of care contact, the diagnosis can actually be made in 90 minutes, and that's a vast difference to 21 days, and this has led to a greatly increased amount of treatment of chlamydia and gonorrhea. And with this particular testing, the vast majority of people in the northern part of Australia are actually being treated for chlamydia or gonorrhea that is asymptomatic in less than 7 days. And this is a fantastic treatment. It means that there's going to be less spread, as well as a decrease in the load of chlamydia and gonorrhea in these regions. So point of care testing, I think, is exciting, and I look forward to the day that we actually have point of care testing in all offices throughout Australia, so we can do a full comprehensive sexual health screening and people can walk away with the results on the same day, and I think that would be amazing. Now, interestingly, there has been an increase in the reduction of the efficacy of ciprofloxacin when it comes to the treatment of gonorrhea. And Elena Trubisky presented where she was looking at what are the can we start creating individualized treatment for gonorrhea in particular people, and how do we identify ciprofloxacin resistant gonorrhea. So her team actually looked at a number of markers associated with resistance, and what they found is that there are particular DNA alleles. The TCC was a form of gonorrhea that is very susceptible to treatment with azithromycin, and there's a TTC that is a mutant form of the DNA that is very resistant to the treatment with azithromycin, and that we're looking at novel ways of being able to test for this resistance, which means we can actually look at the treatment sooner rather than later, and a more effective treatment on the first hit. So they're working on assays for that, and I think that's going to be a very interesting area. Then we from here we kind of moved into the wonderful world of Mycoplasma genitalium, and there was quite a few presentations on this. Out of Melbourne Sexual Health, there was a look at the efficacy of pristinomycin for macrolide resistance Mycoplasma genitalium with Catriona and Bradshaw. This was an interesting treatment because I'm a GP and I don't see massive amounts of Mycoplasma genitalium, but it is certainly around. And what we've found is that there is high levels of resistance to azithromycin with Mycoplasma genitalium, and it would appear that, like say within the MSM community, that it's almost universal that there is macrolide resistance. What the study did show that was pristinomycin, it's a new agent. It works in two different pathways, and it's working well with resistant strains. It appears to have quite a low side effect profile, and when given inadvertently in pregnancy, it is shown to be safe. The suggested dose is somewhere between 2 to 4 grams a day, and that showed a 75% success rate in treatment. It doesn't seem to have any benefit when used with doxycycline. It may not be the most effective treatment available, so it may not be a recommendation, but in pregnancy it may be a choice that's very, very good. There was a presentation by Lit Yin Tang where she was actually looking at ways that we can test for the resistance in Mycoplasma genitalium and she has quite a unique system that's looking for particular sections of the DNA, and that was able to pick up the resistance quite well. And what this found was this particular test is looking for a number of different things. Firstly, Mycoplasma genitalium, then it looks for 5 different strains of resistance and resistance patterns, and this has been shown to be very sensitive and very specific. So hopefully over time this is going to be something that's very, very useful and added to our practice, again meaning that we can treat with the correct antibiotic right from the start. A really interesting look came on next, where we were talking about the microbiological contributing factors towards bacterial vaginosis. We know that it's a common presentation for women. About 30% of women will have bacterial vaginosis at one particular time, and it would appear that there's a number of different factors, mainly overgrowth of anaerobes and the change of the bacterial flora of the vagina to one that is more diverse, and there seems to be a drop in lactobacillus as well. The study was done looking at women who have sex with other women. They looked at 200 women and followed them up for 24 months, and basically the findings show that it is sexually transmitted, and that with increased sexual partners, new bacterial flora is added into the sort of biodiversity of the vagina, and this appears to be what could lead to a tipping point that goes across to bacterial vaginosis. The final presentation in the second session in the morning was a really interesting one by Jason Ong, where he looked at heterosexual men who had been diagnosed with pathogen negative non-gonococcal urethritis, and was trying to see, is there a correlation between their partners and would they become symptomatic as well? And interestingly, yes, it's true that there is a correlation. 60% of the female partners of men diagnosed with pathogen negative NGU were actually symptomatic, and 12% actually had symptoms of PID. So the consequences of this is that men who are diagnosed with pathogen negative NGU, their partners should be notified, tested, and the question was whether or not they should be treated, and if so, with what. So far a really great start to the morning. It's been very interesting, and I look forward to sharing with you this afternoon's presentations.